All right, welcome to the WPS-GHA webinar on medical review findings in outpatient rehabilitative therapy. And today we're focusing on evaluations and reevaluations. My name's Mary Sue Gardner, and I'm a nurse on the Provider Outreach and Education Department. And I'm joined today by my other nurses, Jennifer and Rachel, who will be assisting in the chat and the question and answer portion of today's call. So this is the first of a four-part series that I'm hosting this week on various components of therapy documentation issues. Should you find that you're unable to attend the other parts of this webinar series, they will be posted on our YouTube page as encores within about a week of this event. So on your screen right now is a disclaimer, and our disclaimer we have to show you at every educational event, and it basically says we prepared this for you as a tool to assist you. But note that the Medicare rules often change. So Medicare rules are those relevant laws, rules, regulations that are put out by the Centers for Medicare and Medicaid, and they can be found on the CMS's website. We prepared this information based on those current laws, rules, and regulations. But if they change tomorrow, it's your responsibility to make sure you're following the rules as they are tomorrow. CMS also prohibits you from recording this presentation or making screenshots for any profit-making purposes. But as I mentioned before, we are recording it for you, and it will be available for you on our on our YouTube page. Now, this is a list of acronyms that I may or may not say during the course of this webinar. So these are just some standard acronyms that often come up when we are talking about therapy services. So should I happen to use an acronym that you're unaware of, please just refer back to this section of the slide deck. My overall objection for today is to help you learn about the medical review findings that are surrounding evaluations and reevaluations of therapy services. And I really hope to achieve this by reviewing the coverage criteria with you. We're going to also be discussing the essentials of documentation for evaluations, reevaluations, plans of care. We're going to talk about some of those common findings in medical review that our medical review team sees. And then we're going to talk about how to avoid those findings, as well as give you some tips that are going to help you better document your evaluation and reevaluation services. Now, if you listen to the overall coverage criteria webinar that was held at the end of January, you would have heard me talk about the Benefit Policy Manual, which is Publication 100-02, Chapter 15, Sections 220 and 230. That's where you can find the outpatient regulations for therapy services. The outpatient regulations form the basis of coverage regardless of the place of service. So if you start with the outpatient regulations and then you go to wherever it refers you to other places of service in those outpatient regulations, be that SNF or inpatient rehab facility, et cetera, you'll always be following the most current regs. So if the inpatient services are silent on something, you go ahead and follow the outpatient regulations. All right, so there are four basic criteria for outpatient therapy coverage. And we're going to say this each day this week, just to reiterate this and drive it into your heads. So just a few of those overall coverage criteria, outpatient services. And, your services need to be a need-based service. That means the service requires you, your knowledge, your skills as a licensed therapist. And then that the patient also needs you, your license, your skills, and nobody less than you could help this patient with their overall rehabilitative needs. So you need to have your license. They need you to have that license. If it requires someone less than you, then we don't meet that first requirement. You have to have an established plan of care, which is either made by the physician or non-physician practitioner, but generally that plan of care is made by the therapist. And your care must relate directly and specifically to your plan of care. Services need to be, patient is under the care of a physician, so that the physician doesn't need to write an order, but the physician must certify. And that's how we can see that there is an active physician that is caring for this patient. And then physician certification. Again, that helps to show that that patient is being cared for by a certification. So we don't require an order, but we do require certification to be met. Certification by the physician also helps to achieve these other coverage criteria. So for documentation of these services must contain legible dated signatures. And for today's event, we're really going to focus on the criteria of evaluation, reevaluation, and plan of care, which is your number 2 requirement. So as we move forward, I want to talk a little bit about this graph. So on this slide are the physical therapy evaluation and reevaluation codes that came out in 2017. So this picture actually contains a graph that has information on the physical therapy evaluation codes and the long descriptors of those codes, as well as the necessary information to support the use of the codes. So the information in this picture can actually be found in the CMS 1654F, which was published, that final rule, which was published 11/14 of 2016. Now, the nice part is if you have this slide deck, if you went out to WPS GHA and downloaded this slide deck, you can use either this picture or this icon to hyperlink yourself right to the section of the Federal Register that we're going to talk about. All right. So you can see I brought this up. It was published Tuesday, November 15th, 2016, and it's the final rule, rules and regulations. So the information on the table I showed you that was on the slide can also be found in table 23 of this document. And I know that that is on or starts on page 168. When you look at the graph and the long descriptors associated with each of these codes, and I am going to bring this a little bit bigger so you can see it easier on your screen. All right. So let's take a look at the 97161, for instance. This is the least extensive of the evaluation codes. So it's a low complexity, and you must have all of these things that are required here. And again, if you're looking back on here, it's the same thing, just broken down into a different way. All right. So you must have a history with no personal risk factors or comorbidities that impact your overall plan of care. And you must complete an exam of the body system using standardized tests and measures that are addressing 1 to 2 elements from any of the following. So body structure and functions, activity limitations, and or participation restrictions. There is a clinical presentation component with stable or uncomplicated characteristics. So when we say stable, be cautious on how you document that. Explain the conditions that are not deteriorating. So unstable would mean that a person has ongoing or has deteriorating conditions. If they're stable, explain to us what that means in your eyes. Stable, the word by itself is kind of subjective. It kind of is like the word better. What's doing better? Better than what? Better than me, better than you, better than how I feel. So make sure you use objective and measurable terms when you're describing things like stable. Okay, so clinical decision-making would be of a low complexity. So using some standardized patient assessment instruments or measurable assessments of functional outcome. Typically, evaluations of this nature are about 20 minutes, give or take, of face-to-face with the patient and or family member. But on the flip side, if you look down here at the 97163, which is high complexity physical therapy evaluation, so that requires a history of present problems of 3 or more personal factors and or comorbidities that impact the plan of care. So remember, when you're listing those problems, 3 or more personal factors or comorbidities, they should be ones that would impact your overall plan. There needs to be an exam of the body system, again, using those standardized tests and measurements with a total of 4 or more elements. And again, from any of the following, from the body structure and functions, activity limitations, participation restrictions. Clinical presentation should be unstable and unpredictable. So tell us what is not stable, what is unpredictable, what is, not okay at this point. And then your clinical decision-making, that of a high complexity, using standardized patient assessments, instruments, measurable assessments, functional outcomes. And typically, these are 45 minutes spent face-to-face. So, not a determinant alone of which of these you are going to choose. Time is just one component, and it's in here to say typically 20 minutes, typically 30. But you could have a 45-minute evaluation of very low complexity just because your patient likes to talk. So just because they like to talk and it's taking you a lot longer than it normally would, doesn't mean you can automatically bill a high complexity because you spent 45 minutes. So what's important on this? I just went through and said, kind of gave a breakdown of, the low complexity and the high complexity and what these bullet points mean. These bullet points are the things you should capture within your documentation to support why you chose the code that you chose. So as we scroll down, and what would be your next slide, and as I that up here, and then we go to the OT evaluation codes, I'm going to go back, and I'm just going to scroll down so you can see where these occupational therapy evaluation codes are in the Federal Register. So the top of this page has the reevaluation code for PT, but then goes down and lists the OT evaluation codes. So again, much like the PT evaluation codes, each of the occupational therapy codes have specifics that are for occupational therapy. So medical and therapy history, brief summary. You have to have an assessment that identifies 1 to 3 performance deficits. The difference, whoops, so sorry, I got a little scroll happy. The difference in PT and OT is PT has to have an exam of body systems. OT, they call it an assessment that identifies performance deficits. You also have to have a component of clinical decision-making in occupational therapy. And in physical therapy, you had a 4th component, which was clinical presentation. But in occupational therapy, that does not exist. So clinical decision-making, and it gives you the information on the clinical decision-making, and then it gives you the typical times as well. So again, the important thing to remember here is when you're documenting, make sure your documentation in your assessment and the formulation of your overall plan start to identify all of these elements. And we're going to talk about those elements as well as we move on. So that is going to bring us into the documentation of these evaluation codes. Okay, sorry, my computer was not playing so nice for a little bit. So let's break those down and talk a little bit more about them. Personal factors and comorbidities. So under the personal factors and comorbidities, factors including sex and age and coping style, social background, education professions, past and current experience, overall behavioral pattern and characteristics. These are all things that influence how disability is experienced by each individual. So there could be personal factors that could exist, but may or may not negatively impact the physical therapy plan of care. So make sure you're documenting those personal factors that really influence the patient's participation in the overall plan that you're developing and the ability to progress through it. It's also important that you're documenting the number of personal factors and comorbidities that exist that influence that patient's participation in the plan. The key to listing the personal factors and comorbidities is the impact part. So that's really the part to keep in mind. You need to specify how these could impact or influence how care is rendered and how it affects the patient's ability to participate in the overall plan. Body system elements. Documentation of body system elements should include all body structures and functions to be addressed during treatment. Any activity limitations and any participation restrictions that would be affected by your interventions or the interventions that you're thinking about providing for this patient would fall under here. So in considering body systems and reporting your evaluation, system review should include some of the following things, like for cardiovascular or pulmonary system issues, the assessment of heart rate or respiratory rate or blood pressure or edema. If you're going to be monitoring vital signs during treatment, make sure that's part of your evaluation as well. If it's a skin system, the assessment of like the pliability or texture, presence of scar formation, skin color, skin integrity. If you're working on musculoskeletal system, the assessment of gross symmetry, gross range of motion, gross strength, height, weight, etc. Neuromuscular system, general assessment of gross coordinated movements like balance and gait and locomotion and things like transfers of your patient. and their gross muscle control and motor learning. Let's see. For communication ability, their patient's affect, cognition, language, learning style, the assessment of the ability to make their needs known, consciousness, orientation, are they oriented to person, place, and time? Any kind of expected emotional or behavioral responses, and again, their learning preferences, especially if there's any learning barriers or educational needs that are identified with your patient. So be sure to document and identify these, and also the number of body structures or body functions that are limited. Oftentimes, if they're post-surgical, they may have musculoskeletal, they may have skin issues, they may have some neuromuscular issues as well. So those should be things that you are documenting and gathering within your documentation. So clinical presentation, again, there's an asterisk here because this one is specific to physical therapy services. Make sure you document evidence of the patient's clinical presentation. And again, if it's stable or unstable, if it's evolving, tell us about that. If it's stable, tell us what's stable and how it's stable. Think about the words that are listed here, and you know, time to think of a documenting with a subjective word such as stable or better or improving. Quantify that word with objective and measurable information. Anytime you can give a percentage, a length, a weight, a measurement of any way, shape, or form, it's only going to behoove you to do so. If a patient, if it's like a gait, describe how the gait is abnormal. Is it unsteady? Are they turning the foot in? Are, you know, they falling to one side, or muscular weakness on one side? So make sure you describe those patterns, etc. This becomes part of your overall assessment of the patient. So be sure to include the identification within the assessment portion of the report. Also, be sure to include any evidence of change, such as changing vital sign responses, if there's continuous or intermittent or changing pain levels, what causes those changing pain levels, if they have various or varying levels of awareness or cognitive performance, make sure you mark those down as well. Again, I can't stress enough, anything you document in objective and measurable terms, or any time you can do that, please do. It's only going to behoove you. It's a best way to show if your patient is making overall improvements. All right, and then finally, clinical decision-making again. So let's talk about that. Medical decision-making or clinical decision-making helps to support the complexity of the level of services. So things to document that help support you in your clinical decision-making are things like formulating a complete and accurate description of the patient's condition. And that should focus on the problems. And those problems should be addressed in your overall plan of care. So if you think of data, your initial testing of the patient and how they respond to those tests helps you to influence your overall modalities and the treatments you're going to choose. So make sure you are documenting any data you obtain through testing or through a review of history and information that influence your plan of care. When considering your patient complexity, don't under or overvalue based on the diagnosis alone. Each patient is different and unique, and clinical diagnosis only plays a role in determining the complexity. So you have to consider all the patient risk factors and conditions that may pose a threat to the improvement, and be sure to capture those in your documentation. So demonstrating thorough, effective documentation of your evaluation findings. Those findings should be reflective of your judgment and or your multidimensional thinking. Documentation demonstrating the number of components that the therapist will analyze and examine and coordinate is only going to help support the specific level of clinical decision-making that you are making. And finally, let's talk about functional outcome tools. So although functional reporting is no longer a requirement for outpatient therapy services, the functional outcome tools that you use to measure your patient's ability in a certain category, those are important to capture in your documentation. So if you use a tool to assess your patient's ability, like a tug test, you should also document the results of that. If those results show the need for further treatment, then it should be included in your overall plan of care of your patient. So evaluation complexity level. Finally, as part of your clinical decision-making, you should capture and document the level of complexity of service, whether it's a low, medium, or high. That's part of the components of each of those evaluation code categories. Again, don't under or overestimate the level based on the diagnosis alone. As we mentioned in the previous slides, take into account the number of comorbidities, the conditions that affect treatment, the amount of time it takes to examine or assess the patient and their functional ability, and also the amount of tests that are necessary to complete in order to formulate a good plan of care about your patient's condition. All of this documentation information pretty much will help you pick the correct evaluation code when you go back and look at it. All right, so let's move on and talk a little bit about the coverage criteria for evaluations. And we're going to talk about this quickly because if you listened in January, we went over this, but I think it's important to reiterate. So evaluation and plan of care coverage criteria. Things that you need to know. It needs to be individualized. It needs to be established by either the physician or non-physician practitioner or by the therapist. Generally, 99% of the time, it is formulated by the therapist because you are the ones that are the experts. But it can be formulated by the physician or non-physician practitioner. And it also has to contain legible and dated signature and credentials because we need to know who formulated the plan of care and when it was done. Your evaluation and plan needs to be established before starting treatment. That doesn't mean you can't evaluate and treat on the same day. It just means that before you do your next date of service, it needs to be put into formal writing and put into a formal plan. You're going to periodically review your evaluation and plan of care, and that's what you do when you do your progress notes, which we'll talk about tomorrow. And then again, any changes to your evaluation and plan of care can only be made by the therapist, the physician, or the non-physician practitioner. Anyone less than you, like a therapy assistant, a PTA, a CODA, OTA, cannot make any changes to your evaluation and plan. Now, reevaluations are not routine. So reevaluations are not routine and recurring services. They're only covered if the documentation supports the need. So this could be due to a new clinical finding, but mostly these come about when there are significant changes in the patient's condition and it's going to warrant a reevaluation. So the key here is significant changes. And we're going to talk about this in a second. As providers of this service, you're required to constantly reassess your patients. This, again, is what you do via your progress notes. So you're constantly reassessing them. You're making sure they're on track of their goals. But then you are going to do a reevaluation, which is billable to the Medicare system. It has to be because something unexpected arose that significantly changes your overall plan of care. So what does that mean? What does significant changes mean? If you're treating a patient and there's significant changes to that patient that require a revision to your long-term goals, then it may warrant a reevaluation. Same as evaluation and development of your overall plan of care. A reevaluation can only be done by the therapist or physician or non-physician practitioner. So some examples of significant change include like a new condition that rises unexpectedly. When a patient's not responding to the current treatment plan. So you develop this overall treatment plan and you get in there and you start doing it and the patient is none of what you expected at all. And so you basically have to scrap it and start all over. If there are new significant findings, or the key to remember, all of these things generally unpredictable. All right. Overall evaluation and the plan of care can be one document or it can be two separate documents. Medicare we don't care either way. The evaluation part is essential to the development of the plan of care and those treatment goals and interventions. So when you're developing your plan, it must be consistent with your evaluation findings. Again, it has to be established by the therapist, physician, or non-physician practitioner. It's going to include your functional assessments and your measurements, and it's going to relate directly to that plan. Your evaluation needs to contain therapy and medical diagnoses. You need to have long-term goals. You need to have the type, amount, frequency, and duration of the services you're going to be providing. And finally, it needs to be signed and dated and contain legible identifiers of who performed the service. So continuing on, a reevaluation, again, to reiterate, not routine. They're completed because of new findings, significant changes in conditions that are unanticipated. And remember, they're billable when they meet these criteria and they're deemed medically reasonable and necessary. So that takes us to our common findings of things that our medical review department sees when reviewing claims, specifically regarding evaluations and reevaluations and plan of care. So the first issue is just no functional assessments or measurements. So this is missing components of that eval, reeval, and plan of care. So we don't know how you got to what you got to because we don't have any documentation of the assessments or those measurements. You're missing long-term goals. So you just don't have any listed or you did not submit them. No documentation of amount, frequency, and duration. So when we talk amount, frequency, and duration, how many times per day, once a day, twice a day, how many days during that week, and how long do we think that'll last? Are we going to see the patient once a day, 3 times a week for 4 weeks? When we talk about duration especially, You want to make your duration a specific amount of weeks that you believe it's going to take you to get that patient better. If you're going to go with a range, you would go with the range in your frequency, 2 to 3 times a week for 4 weeks. Because when your physician certifies, and we're going to talk about certification later in the week, I believe that's on Wednesday, we need to have exactly how long that physician is going to certify for. Because your treatment plan is then only good for the duration of your plan of care, or 90 days if that duration is listed that way. So is it acceptable to have a range? Yes, when it comes to frequency, but not when it comes to duration. And then other components that have been missing, signature and professional identifier. We have to verify who did it and that it was the correct person. All right. So as we move on, billing unnecessary reevaluations is the next finding. Remember, in order to bill for a formal reevaluation, there needs to be a documented significant change in the patient to support the reason for the reevaluation. What are the unanticipated clinical findings? Is this routine? If so, that's a no-go. So if you just do a reevaluation and bill the Medicare system at the end of every month, no, we're not going to pay you. It's going to be a finding, and it could lead you to allegations of potential abuse or fraud. So know that reevaluations are billable to Medicare, but are billable only when the documentation supports there is a significant change in functional status. Reassessments are ongoing and should be done with each of your progress notes. All right. Evaluations and reevaluations not completed by the correct authorized people. And that's why I've said so many times, we need that signature, we need a valid, legible signature, and we need the professional identification, because therapy assistants cannot write or make changes to an evaluation, to a reevaluation, or to a plan of care. So we have to verify when we're doing medical review that the correct person actually completed the required components of documentation. And then let's end with some tips for documenting your evaluation, reevaluation, overall plan of care. So your evaluation should set the expectation of your overall plan of care. It is a written report of your clinical exam, and it has things like your history, the review of the systems, how many systems, the tests and measures that you did, the outcomes of those, the patient's presentation, findings that you have regarding that patient, and any treatment recommendations and modalities of treatment. Your documentation must contain minutes, actual minutes, not the time the patient walked into the therapy suite and walked out of the therapy suite. We want to know how much time was spent in each modality of service. So when it comes to your evaluation and reevaluation and formulation of your plan of care, we need to know the actual amount of minutes that it took for you to do that. Remember, your plans of care should be individualized. It should list the treatments that should be provided. It should contain goals with amount, frequency, and duration, and signatures and credentials. All right, so that was a lot for 40 minutes. So this time, I'm just going to say my objective for today was that you learned how to avoid some of those MR findings in your documentation of evaluations and reevaluations. And I hope we accomplished this today by reviewing that coverage criteria. We went over what should be in your documentation and those documentation essentials for evaluations, reevaluations, and plan of care, as well as some of the common findings to help you avoid these. So at this time, I am going to ask Jennifer if we have any questions that have come into the chat that we have not answered at this time. So Jennifer?
Yes, Mary Sue, we did have one question that was just asking for a clarification. Referring to orders, does the physician need to write an initial order to evaluate the patient?
No, so orders for outpatient therapy services are not required by Medicare. However, in order for us to prove that there is physician involvement, you need to have the certified plan of care. So that's kind of how Medicare gets around that direct access component, because all states have direct access now. And, you know, someone can come in and request therapy services without a physician order. But for Medicare, since we're a physician-directed program, we want to see the physician involvement. So no, you don't have to have an order, but yes, you do have to have your overall plan of care certified. Any other questions, Jennifer?
No, you answered all the rest of the questions.
All right, and I do see there was one question that came in about range, and I did stress that, like documenting frequency range, like 3 to 4 visits a week, and it is acceptable to document that, and we would expect that the frequency of your patient care does go down as the patient progresses through therapy. And so, you know, you don't have to go back and change it. It's something, you know, that would be generally expected. But don't do a frequency when it comes to duration or overall time you're going to spend in therapy. All right. On behalf of Provider Outreach and Education, as well as our Medical Review Department, we want to thank you for taking part in this educational event. We look forward to your participation in future events. So at this time, you may now disconnect.